but it will arrive a bit later. Welcome everybody to our annual Innoboot seminar. The Innoboot seminar is a yearly seminar organized by Radboud University, Radboud University Medical Center, Hogeschool van Arnhem, Nijmegen and Briskr. And this year we have organized the seminar also together with Foodvalley, which is of course logical considering our topic today. Last year we hoped this session of Innoboot would be live again this year, but alas, we have to do it online due to the current COVID situation that is still ongoing. And even though I suppose we have all gotten more used to doing it online, I still look forward to meeting you all in real life next year, because I think the chances for next year are a lot higher than we thought last year, this year would be. Yes, the topic for today, you are what you eat. We know this for a long time, but still food intake has received little attention from the perspective of healthcare professionals. Until recently, the importance of food on health was only a very minor part of medicine training, and how often addresses a GP proactively the weight of their patients who are clearly overweight. But phrasing Bob Dylan, the times they are changing. Our knowledge about the interaction between food and health is growing rapidly and is becoming more and more part of the normal toolkit of healthcare professionals. And not only the food itself, but also our context and motives for making healthy or unhealthy food choices is more and more an object of study. And of course, this study finds its way into healthcare today, either from a prevention point of view or even as a food as medicine point of view. In the program today, we dive into different aspects relating to food and healthcare. We will start with a presentation from Pim Assendelft, professor at Radboud University Medical Center and GP, who will talk about the role of food in prevention. Unhealthy eating habits and being overweight are an important risk factor, of course, for future diseases. After Pim's presentation, we will have 2 rounds of parallel presentations of different subtopics in relation to food and health. Boukje van de Heuvel from Radboud University Medical Center and George Verlaan from Friesland Campina will talk about the role of food and exercise to be better prepared for surgery and therefore create better outcomes. Alex van Kraai and Sander Hermsen from One Planet Research Center will talk in a different workshop about working with citizens, especially with lower socioeconomic backgrounds, and how they can influence choices on food and healthy lifestyle. And especially, of course, what can we learn directly also from citizens there. Karin Struijs and Samantha Hughes, both from Han Biocenter, do research on CBD. I had to look that one up, cannabidiol, oil made from fiber hemp and how this can help in relation to healthy aging. And the 4th and last parallel presentation is organized around healthy food startups and how innovative market approaches can help create better sustainable business and have a positive health effect on consumers by helping them make more healthy choices. As said, all 4 presentations will be held twice parallel, so you have the opportunity to visit 2 of these. At the end of the seminar, we will have a presentation from Ariane de Jong from Albert Heijn. Stimulating healthy food is of course not something only for medical professionals, but supermarkets play a major role in what kind of choices we make in buying and preparing and eating food. Cooperation between healthcare and the food sector, and especially of course supermarkets, is hugely important, I think. And therefore we're happy that Ariane will give an insight from Albert Heijn on this. Enough talk. So enough to talk about this afternoon. We have made a full program that touches on all these topics. But before we go there, first a few house rules. Due to the size of the group, please unmute and have all your microphones unmuted. If you want to ask a question, we would like to have the questions in the chat, so I can ask them to the presenter. If possible, please leave your video on during the presentations. It's always nicer for presenters to talk to people. And even though they are just digital images on a screen, the plenary session will be recorded and only active speakers can be seen on the recording. Marion will create 4 breakout rooms for the parallel workshops that you can join after the plenary session during the 10-minute break. And after the first round of workshop, there is again a 10-minute break and everybody is able to switch to a new breakout room. Around 5 minutes past 4, we will come back together in the plenary session for the final keynote of Ariane from Albert Heijn. And at the end of the seminar, there's the possibility of online networking and discuss the presentations of today and meet new people. For this, Marion will place everybody totally at random in small groups. It's one of the surprises for me that I think always in all these online meetings, the getting together in these random groups is always quite nice, because you often talk to people that you otherwise would not have talked to if you would have met each other physically, simply because you wouldn't have known them. So it's a good way to meet new people. So please hang on there. And last but not least, it's always nice to get an applause after the presentation, but applause in an online setting is always hard. So I suggest we do it in sign language like deaf people use, and this is sort of the applause. So maybe test it to go to the, very good, to go to the first speaker. I wish you all an interesting afternoon. And I invite Pim to share his screen and start his presentation. Pim, the floor is yours.
Yeah. Is my presentation visible?
It is.
Yeah. Well, thank you, Martijn. Thanks for the invitation. And I just make a sort of kickoff. And I think some topics touch the topics of the small group meetings. So I'm just going to make a broader perspective. My name is Pim Assendelft. I'm Professor Prevention in Healthcare at Radboud University at the Department of Primary and Community Care. And I have a background as a general practitioner. Well, first, if we're talking about prevention and about lifestyle, we have to acknowledge that it's only a part, that lifestyle and food is only a very small part of all prevention. Prevention is also vaccination, it's fighting air pollution, and also fixing things in your molecules and genes. So prevention, if we're talking about prevention, we have to define it a little bit. And this afternoon, we're talking about lifestyle and especially about food, but it's only a part of preventive things. The other thing that we have to realize is that most people, if they think about prevention, they think that it's about people that are not ill and should not get ill. But from the perspective of healthcare, prevention is much more. It can be part of taking care of high-risk people, but it's only part of treatment. Like if somebody has diabetes and you advise to lose weight and walk, it's also a way. And also rehabilitation after a myocardial infarction is also a way of lifestyle advice and of prevention. So altogether we call it health promotion. And from this afternoon, or for this presentation, I mainly focus on the right side of this slide. Well, and Martijn already referred to it. Prevention in healthcare is my hobby, but until quite recently, it was quite a masochistic hobby. If I gave presentations, everybody was just smiling at me and had a sort of resistance against what I was trying to tell. And it's only for the last years that more and more in reports within medicine, there's a lot of attention from the Royal College of Physicians, from the medical specialists, from the general practitioners, and most recently last year, the final requirements of the medical education, so to become a doctor, have been revised, and there's a lot of prevention and lifestyle and food in that. So the doctor of the future will be more capable of giving proper lifestyle advice. But why do we do this all? Is food important? Well, if you look at the upper part of this slide, you see that given the behavioral factors contributing to health and disease, you see that an unhealthy diet is contributing after smoking for 8% to the burden of disease that we have in the Netherlands. But if you look at the number of deaths and the number of, especially the costs, especially the costs, food is related to most care costs compared to, for example, smoking. And why is that? It's because the diseases related to smoking are more deadly than diseases related to food. So for Dutch healthcare, it's very important to pay enough attention to food. The lower part of the figure, it's all kind of metabolic derangements that you can have, like high blood pressure, fasting blood glucose, overweight, a high cholesterol, and a low mineral bone density. And you see that they all also contribute to this burden of disease and to the costs. And they are all related to food. Food is having an important part in all these kind of ailments. The first thing, if you talk with physicians and talk about lifestyle and food, they say, oh, lifestyle, there's no evidence for that. But here you see some mainly Dutch reports and websites that clearly determine, if we look at food, that there's enough evidence. There's enough evidence, underlying evidence, for our food recommendations from the Netherlands Nutrition Center. There are even specialized reports on food as part of the treatment. And there's even recently, on the right lower part of the slide, recently even a special study book for physicians dealing about lifestyle, and food is having a very important role in that. So it's getting more and more important politically, as I already said, but also if you look at the content of evidence below food as medicine. Another thing that Martijn asked me to address is, and that's maybe an important thing, is that it's quite difficult to really pay attention to behavioral parts of food and overweight. But for the last 2 years, there's a reimbursed program in the Netherlands. It's called a combined lifestyle intervention, or in Dutch, gecombineerde leefstijlinterventie. That started 2 years ago. It's completely covered. Even your own risk is not spent by it. And it's a combination of treatments focused on healthier food and eating, exercise, and also, when necessary, psychological treatment. They have to be proven effective. So there's a special center at the Dutch National Institutes of Health that say which one is good and which one is still needs to have the certificate. And the referral is by the general practitioner with a very low referral threshold. So if you're only overweight, that's half of the Dutch population, and you have one risk factor, you can already be referred. Or if you have obesity and BMI over 30, you can directly be referred for this, even if you don't have any disease. So that's an option, I think, for the people interested in food and health to focus you on this program, perhaps. Oops. Well, I was talking about some indications for diseases in relation to food, but here you see a long list from an American website from the American National Institutes of Health. What kind of diseases have special requirements for food as a treatment? So I think that there's a lot of specialized knowledge necessary, and there's a lot of infrastructure, logistics necessary behind it to deliver the proper diet at people's home. And I think that you will hear more about that in the subsessions. Then some issues on health and food. The first one is all these fancy new diets, and everyone lasts mostly only a year, and then they disappear again. And why do I show you this? Most of the time, the background ideas of these diets are not even that bad. The problem is that if people follow a lot of different kind of these diets, which most of them are having one or two factors that they focus on, high fat, low carb, the POP diet, etc., that it's proven that people that use a lot of these diets after each other, they mainly gain weight, because every time the body recovers from the diet period and gets to a higher set point. So it's much better, is my idea, to have a much maybe less fancy and less strict diet, but keep it, than follow all these kind of fancy diets. Another one is that we more and more start to understand why diet is such an important factor and why it has such widespread influence on the body, including the brain, the way that you concentrate, or depression, for example. And that's because the bacteria in your guts, they digest the food, and all kinds of molecules come from this process, and they get into your blood, and they have all kinds of actions. For example, low-grade inflammation. So by studying this microbiome, as they call it, we more and more start to understand how it works in health and disease, and also how we can interfere with diets on these underlying illness processes. Another one is the measurable self. It's often very nice if you want to focus on what is the most proper diet for me, that you can directly have a feedback on how it works on your body. This is a slide from One Planet, and it provides all kinds of measurements that is possible. On the lower left side, you see the smart toilet. Here from your urine and stools, molecules can be extracted to give feedback. We have an indigestible, so you swallow a sort of pill which monitors during the travel through your gastrointestinal system how the condition is. And there is also a smartwatch, etc. And if you combine all these data together, you get a sort of digital twin of your nutritional status. Well, if I talk about health and food, I also feel forced to look at the bigger picture, because now I only talked about individuals, but I think it's fair to also think about the food, of the role of the food infrastructure logistics on health. If we think, for example, about avocados, they have to come from abroad, and a lot of so-called healthy foods are brought in by ships. Another thing is that, for example, fish, it's an important part of our diet, but there are also countersides of increased fishing. So I just want to say that if we think about a healthy diet, we should think about a healthy diet for ourselves, but also about a healthy diet for the planet and our fellow citizens, and for the animals, for example. It's just a thing I would like to address. Well, this is Bet. It's one of my favorite patients. And if I talk about Bet with students in training, they immediately can think about 15 diseases that Bet, although he's not so old, can already have. And if I ask them, what should we do with Bet? They have all kinds of interventions, food interventions, walking, psychological, etc. But if I look at the background of Bet, he says, listen, doctor, I have a lot of stress. I lost my job. I have bad housing. I cannot see my children. I'm divorced. And I want to work on this first. And what you see is that a lot of lifestyle factors are influenced by psychosocial factors. And are these psychosocial factors evenly distributed? No. If we look at, for example, your educational status, you see that people that have low education live 6 years shorter than people with a higher education. But even worse is that the years that you live in perceived good health, so when you start to feel the idea, get the idea, I'm not feeling well, makes an enormous difference. 53 for lower educated people and 72 for people that have higher education. And lifestyle is one of the factors that is underlying this. Here you see the difference, and here you see it at this moment, of what percentage of the people is having obesity. And you see for lower educated people, you see it here, it's more than double from the higher educated people. But you see in the future, the balance between it will be the same, but in absolute numbers, the increase is much higher in the lower educated group than in the higher educated group. And in 2040, 1/3 of the population is obese. And if you have a BMI of 30, you're really fat. And it's related to a lot of diseases. But I still want to stress again the socio-economic health differences, which is caused partially by lifestyle. And I think we should try to focus that this gap will not be broader in the forthcoming decades. On this slide, I would like to show you that food and eating is a behavioral thing. And it's determined by your self-image. It's determined by how the environment is made up, how easy food can be get. And well, for example, healthy food is more expensive than unhealthy food. But also the interaction between other lifestyle factors like smoking or exercise with food. And it's also a social happening, like the people you're living with and the group that you're in mainly determines what kind of diet you follow or can follow. So most of you will think about an individual, but also think about the bigger picture if you're thinking about this food behavior. And then the question, what is good food? Because doctors always question that and patients as well. And my most simple answer as a GP is just follow the Wheel of Five, which is issued by the Dutch Center for Nutrition, and it's supported by the Dutch College Gezondheidsraad Health Council. And that wheel is not so difficult. It's vegetables, it's healthy oils, it's protein sources, it's carbohydrate sources, and it's about drinking sufficiently. And it's my idea that if we just would be, as a population and also most individuals, if we would just focus on this Wheel of Five, that also enables us to eat food from our direct surroundings. So food of the season, for example, we would be very good off. So I propose the Wheel of Five instead of all kind of special and fancy diets for the mainstream of patients. But as I already told you, there's also more and more knowledge about specific diets that are often more complicated, but sometimes very efficient for all kinds of diseases. And the knowledge of that is increasing every time. Another thing that I would like to stress is that the food requirements are different regarding at what stage of the life cycle you are. And I don't have to illustrate it because I think the pictures illustrated that a child or a young adult or an elderly have different needs. And for example, the elderly, they need sufficient protein to maintain their muscle strength and also extra vitamin D. So we have to think about specific requirements that are necessary. Then, well, I was asked to tell about food in healthcare, but there's also the question of where in healthcare. And Boukje van der Heuvel in her workshop, I'm not advertising her workshop because you have to come to my workshop, but she will tell about fit for surgery, which is in the hospital. But if you think about the whole healthcare chain, let's say that I, as a general practitioner, make an indication for an operation. There's a waiting list because of COVID. Then at home, I can already start with interventions. I can refer somebody to a dietitian. I can give advice to start walking, for example, to lose weight. Then there's a sort of workup that's like fit for surgery, that people on the waiting list under the supervision of the hospital already, so that's more intensive, get a special program to get as fit as possible for the operation. And it's proven that it saves recovery days, and there's much less side effects of the operation then. Then there's the recovery itself after the operation, and we get people early out of the bed, but we want them to eat normal as soon as possible. And that means, for example, that we have to divide the portions of the meals in very small parts to make it possible for people to get enough nutrients. Then we have the aftercare, that's radiation therapy, for example, or chemotherapy. And also food can support people to sustain this kind of treatments. And then after a treatment, people are hoping that the disease doesn't come back. Let's say cancer or a myocardial infarction. And also lifestyle can play a role in reducing your risk that the disease recurs again. And then after a while, this window frame of higher risk of recurrence has faded away. And then, of course, we in the healthcare system want people to stay as healthy as possible and hope that they don't get other diseases. So also in healthcare, we have different requirements for the food, depending on the stage where you are in. This is, if I look at, for example, cancer, this is specialist work. But the challenge is how to get all this specialist knowledge at home for the patients, because that's the place where people eat and stay most of the time. So wrapping up, and I hope I'm still in time, Martijn. Food for prevention. Well, I hope that I try to convince you that the role of food is crystal clear in healthcare. There are generic recommendations like from the Health Council for general health, and that's out of debate. There's enough supporting evidence and more specific guidelines for specific diseases. And there are several trends like fancy diets. Well, you know what I think about it. It's better to just follow the wheel of five. The microbiome, which makes us easier to understand the role of food, and technology for the personalized self. And I think the next decade, this will play a major role. Be aware of increasing socioeconomic health differences in focusing on healthy nutrition. So also focus on people from these lower classes with lower health literacy. And to wrap up, nutrition is behavior, and behavior is very complex. So it's not an issue that can be fixed easy. It takes time from the healthcare system, and also time from society to make a healthier environment for people to make the healthy choice the easiest choice. And that's my presentation for now.
Thank you very much, Pim. Maybe a round of applause by everybody. Thank you. Thank you for your presentation. There was one question in the chat from Paul van der Hoeven, whom you probably know. Health food is more expensive than unhealthy food, ? If I go to the market, I see vegetables for very acceptable prices. Can you give examples of less expensive unhealthy food?
Less expensive unhealthy food. Yeah, I can give you, well, if I go to the Albert Heijn, can make, well, it's recorded, so. Buying frozen fries per kilo is less expensive than buying fresh potatoes. A kilo of fries is less expensive than a kilo of potatoes, which is weird. So that's one example that I saw, for example.
For example, also processed meat is often less expensive than the vegetarian choice, for example. Things like that.
Yeah, but on the other hand, well, I say it more in general, but if you look at what people need, and if you also look at what people buy that they don't need, I think with the average income of the Netherlands, and also with people even in lower incomes, it must be possible to eat healthy, sufficiently healthy. But on the other hand, and that's also a thing about, that's why I say it in this context, don't make diets that make it possible to follow the diets only for people that are having sufficient money. So that's why I told it.
Yeah, clear. And one of the things that you mentioned in your presentation is, of course, the big difference of 15 healthy life years between lower and higher social economic status. And if I look at many of the projects that we did the last, maybe even decades, around healthy life choices, is that what we've seen, we've been seeing growing that gap between high and lower, not because the lower social economic status became less healthy. Everybody became a bit more healthy, but it worked a lot better in the higher social economic status, so the gap was growing. What are your suggestions if you look at how can we reach that group, lower social economic status?
Yeah, well, I sensed from the workshops that Sander is also having something about. I think, and we all acknowledge it as researchers, but also in politics, is that the people that until now were in charge were the higher educated, white, older, elder, and maybe even male persons. And what we see is that we have to go to the persons that it concerns and start talking about their needs, the way that they want to be approached, their disappointments about previous attempts, etc. So I think we have to go really back to the basics. That's one. The other one is the importance of the environment. More and more you hear about sugar tax, etc., that we also think that we have to protect people from too strong influences because you can almost not win from that. So that's another part, and that's politics. But I think that health protection by taxation, by laws, by, for example, the distance between a snack bar and a school, for things like that. I think that's also a part that we really have to face. And there's resistance against it. That was the same when we started with trying to get the smoking rates lower. It takes time, but I think in the next 10, 20 years, people will be more supporting also these kind of measures.
Yeah, and if you look at the responsibility for changing that behavior, of course, the person itself is responsible, which is of course logical, but do you see the responsibility more from the side of the healthcare professionals, or, for example, looking forward to the Albert Heijn story, also in the supermarkets and other food companies, do they also have a responsibility?
Yeah, well, that's what you also see in all kind of reports. It's and. Everybody has his or her role. The supermarket, the municipality, the schools, the healthcare workers, whatever. The role of healthcare could be that we have a very low threshold entrance to people that are usually difficult to reach by, for example, municipal health services. And we can try to use the health complaints that people have to start the discussion and to offer ways to change life. And it's an offer, it's not an obligation, because then you get resistance. So everybody has his role. And like in Nijmegen, we have Nijmegen, groen gezond, green healthy, and in movement, groen gezond en in beweging. And that's, and it also has a local health arrangement between all kind of parties. And I think it's very important, employers, I should not forget, to try to all work together, because it's a multidimensional problem. And I think also the solution is multidimensional.
Yeah, yes, no silver bullets available for this.
Unfortunately not.
No. There's somebody that also asks if you're involved in One Planet.
If I'm involved, yes, yeah. I'm a strategic advisor from Radboud UMC. So we try to leverage, to bridge between the possibilities of One Planet at one side and the knowledge that Radboud UMC has. So sometimes One Planet gets a contact with a company, for example, or gets a good idea itself. And then we connect it with specialists that can help to figure it out. And now we are just thinking about the other way around. And that's starting after the summer, that we make a contest of researchers and we ask them if in collaboration they have good ideas for one planet. So that's the other part that we're going to do. So we are closely collaborating, me as a person, but also Radboudumc with one planet.
Okay, nice. Maybe considering time, the last question. Somebody asked, microbiome plays an important role in nutrients absorption. What about nutrigenetics in terms of how much does the genetic differences between people differ a lot also in what the effect is of that?
Yeah, well, it must be there. Because for every physiological thing, there's an individual variation on an external stress. So it's, well, we see it with COVID. Some people end up on intensive care and the other ones just walk on. That's the same with the microbiome and also the effect of food on the microbiome. It's an interaction of these facts, and people are trying to sort all these kind of things out. The problem is that if you look at for example, genetics and families, etc., is that food is partially, or in families, like also with obesity, for example, if there's obesity in a family, you never know if it's through the pathway of genetics or through the pathway of behavior. And that's the same with this, that you are not sure whether it is because of the genetics or because of the food behavior. And it's very difficult sometimes to disentangle that.
Okay, thank you very much. There's one remark that's maybe nice to show. I didn't know that. Somebody says one of the biggest employers of the Netherlands, the Army, is giving their employees, new recruits, cooking lessons to show the value of nutrition. I think that's a nice idea. Thank you again for answering the questions. One final applause for you. Thank you. I think we now have a short break, and at what was it? The 2:15. We invite everybody to be present at that moment in the workshops.
I will open the breakout rooms now, but you can get a cup of coffee after you've chosen your room.
Thank you very much.